Hey guys, it's the final podcast for chapter 15. I'm having difficulty. I have several videos of surgeries, but when I play them on a podcast like this, you hear no explanation from the video. So I'm not going to show the videos. They are in the PowerPoints, and I do expect you to look at them. But we are going to talk about post-surgical care of common surgeries, and and I can talk about different procedures. All right, the first surgery is a laminectomy, and when you watch the video, you will see that they remove the lamina. This is good for decompression, often used in spinal stenosis and anytime that there's too much compression in the spine. These are fairly common surgeries. You will see patients post-operatively, and we're going to be talking about post-operative care here in a minute. A discectomy is when they go in and remove the parts of the disc that are compressing either the nerve root or the spinal cord. The term ectomy usually means to remove something. Realize they're not removing the entire disc. They're removing the part that's bulging out. It's kind of like a meniscectomy. Patients always wonder what happened. What are they? Now my knees are bone on bone because they took away my meniscus. Well, they just took away the part that was damaged. So in the lumbar discectomy, you will see the same thing. And spinal fusion, again, there's a video. When you watch the video, you will see that there's several different methods you can use for fusion. They can only use metal, they can use bone. In the cervical spine, they often go in anteriorly. If you think about the anatomy of the cervical spine and how difficult it would be to get to the disc area, the way that the facet joints are lined up, and the small amount of anatomy. So they often go in, they push the trachea to the side, and they do the fusion anteriorly. Okay, when a patient has had any type of surgery, initially that maximum protection phase is very important. Postoperative management following surgery is rarely very dynamic. You work significantly to stabilize and to limit motion. Typically, patient education, they tell patients no heavy lifting for up to 3 months, depending on the surgery. Active motion, especially with, say, a fusion, is limited. We want those the surgical fusion to take hold, and so whether they used their pelvic bone, usually they may use bone from the iliac crest, they may use cadaver bone, they may use a metal plate, but it's still unstable until things start to heal. Movement is usually contraindicated. If it's a significant fusion or if motion is not wanted, they may even come in a TLSO, which is a thoracic lumbar stabilization orthotic, and this prevents the individual from bending forward. Wound management and pain control is what you would initially do, especially in the hospital or on those first few days of outpatient therapy. You need to look for signs of inflammation, such as redness, swelling, or any non-closure of the wound. And you can do things for pain control, such as cryotherapy, TENS or interferential E-stim, and those all may help. The patient must learn bed mobility without rotation of the spine, and so contracting their transverse abdominis and stabilizing their spine using their abdominal muscles, then log rolling onto their side, kicking their feet off the edge of the bed, and sitting up as one whole unit is important. That is one of the first things you need to teach a patient when they are having difficulty with bed mobility, and especially after surgery. Bracing exercises. I'm sorry, that's not bracing exercises, those are braces. So they may, if somebody who's had an anterior cervical discectomy and fusion, so how I said in the cervical spine they go anteriorly, sometimes they're put in either a Philadelphia collar, which is a harder cervical collar, or a soft collar. That is very dependent on how extensive the surgery was. So it's common to not get that for very long, if at all, after surgery. But if there was a significant amount of surgery, they may come in a cervical collar. Same thing if flexion is so contraindicated based on the fusion, they may come in a thoracolumbar brace. And then exercises. You want to encourage walking. Many surgeons will say they want the patient walking at least a mile within a month. And so nothing quick, no inclines, nothing aggressive, but getting up and moving is a good idea. You want to encourage upper and lower extremity range of motion that doesn't affect the back. If the patient is bedridden, make sure you're teaching them core stabilization exercises, heel slides, long arc quads, the easy exercises they can do supine without stressing their back. But they should not be in bed very long. And so within a day or two, when they get up, you can start slightly more dynamic exercises, ensuring that the spine stays in neutral as much as possible. All right, for these post-operative patients, they will move into that moderate and minimum protection to no protection phase. So hopefully eventually the patient can get back to doing all their normal activities. Once they are able to have less restrictions and can move into that moderate and minimum protection phase, you want to work on scar mobilization. You don't want scar adherence, so making sure you do scar massage. Do any stretching and joint mobilizations and manipulations to restricted tissue, but realize if they had a fusion, that is contraindicated to mobilization and manipulation at that area. What you may see, and we discussed this a little bit, is if they have a fusion in one area, they may have limitations somewhere else with either hypermobility, or maybe their hips are hypomobile and they may need to have those stretched out. So when I'm talking about manipulation and mobilization, we're more thinking the joints in other areas, not the ones that were fused. Work on muscle performance, and this can be core strength or lower extremity strength. And gait training. You want to make sure the patient ambulates with a fully upright posture. There's no limping, no lateral lean, so that they can have a much more significant normally gait pattern. Make sure that you follow the surgeon's contraindication. So if the surgeon says, do not do this, they have seen the inside of that spine, and they know, hopefully, if they're a good surgeon, they know the proper ways that physical therapy can help the patient. All right, some other special types of problems that don't necessarily fit into those biases that we talked about, and one is compression fracture. Usually this is secondary to osteoporosis. You will see in this area, you'll see people have compression fractures from doing airborne operations. So a fall from a significant height can lead to a compression fracture. For these individuals, you want to teach stabilization exercises, making sure that you promote neutral thoracolumbar movement. Okay, so you don't, or no movement at all. You want to make sure the patient can stay in neutral, and you help them develop that spinal stability. Teach any kind of postural correction, including scapular retraction exercises, so that they don't get an increase in thoracic kyphosis, which is commonly seen in those with osteoporosis. Stretch any tight musculature, especially musculature that's limiting proper posture. Make sure as you're stretching that you are not flexing the lumbar spine or the thoracic spine. And then instruct the patient on correct lifting techniques. If they are able to get back to normal activities, make sure that you're teaching them how to do those normal activities without trunk flexion. All right, now we're going to talk about individuals with spondylolisthesis. So spondylolisthesis is an anterior slippage of one vertebrae on the other. The above or the higher vertebrae slips on the lower. So you may have an L3 on L4 or an L4 on L5. These are graded on a grade of 1, 2, 3, and 4. So grade 1 is up to 25% slippage, and how they measure that is the size of the vertebral body. So if only 25% of the vertebral body is slipping anteriorly, that's considered a grade 1. Grade 2 is 26 to 50, grade 3, 51 to 75, and grade 4 is more than 75 anterior slippage. When you get to the higher grades, you often get a fracture of the vertebral arch. You may get degenerative changes noted with this. So obviously in these patients, you are going to avoid manipulating them. They are already highly unstable, and performing a manipulation can cause significant problems. So what do you want to do? So these people are unstable. They have hypermobility related to this spondylolisthesis, and you want to work on stabilization. Most of these patients do better with a flexion-based approach. Okay, they're already if you extend their vertebrae, you're going to cause more instability. Don't forget to work on both segmental and global stabilizers of the spine. Stretch out their hip flexors, their iliopsoas, maybe pulling those vertebrae even more anteriorly. You can do grade 1 and 2 mobilizations for pain if the patient can tolerate that. And if so, you would probably push on the grade or the vertebrae below to allow movement back into place. But again, any manipulation is contraindicated. All right, another special population is those with ankylosing spondylitis. So ankylosing spondylitis is a rheumatic disorder that results in the eventual ossification of both the anterior and the posterior longitudinal ligaments and of the facet joints. So these people get stuck. They have very limited motion. It usually appears in adolescence and kind of peaks in the mid-20s. So older individuals are not diagnosed with this. They usually have already, if you're 50 and you have ankylosing spondylitis, you developed it in your 20s. And people usually have pain bilaterally in their lumbar, sacral, and thoracic joints, sometimes even in their shoulders and feet. Right, typical symptoms of this, people will have stiffness for more than 30 minutes. Their back pain actually improves when they're moving around and getting exercise, but it doesn't improve with resting. The pain may wake them up at night, especially the second half of the night, and it may alternate from one side to the other. So maybe the right side is worse for a bit and then the left, and it may even seem like buttock pain. All right, how can we treat this? We cannot change as a PT the progression of this ankylosing spondylitis. Our goal is to educate the patient about proper posture so that as their bones start to fuse together, they are able to maintain a good upright posture. You may have the patient sleep in a prone position or use a pillow or towel roll behind their lumbar spine when sitting to help maintain a lordosis of the lumbar spine and to avoid too much kyphosis of the thoracic spine. And what else can we do to treat? So if the patient is not fused and they're painful, you can do gentle grade 1-2 mobilizations for pain control of any non-ankylosed segment, so non-fused segment. Working both segmental and global trunk stabilization, which may sound counterintuitive because the patient is fusing. Why do you want to stabilize? Well, you still want those muscles to work so that they can keep that spine in a proper position. And strengthen any of the muscles surrounding the spine. Also make sure that you maintain flexibility in the hip and shoulder, because that may eventually be lost if not used, and it may also be affected by the ankylosing spondylitis. Okay, so cervical and upper thoracic regions, some of the special populations would be those who have tension or cervical headaches. You will see a lot of patients with cervical headaches and they come to physical therapy. About 15 to 20% of those who have recurrent headaches, it is a cervical related headache. Some of the risk factors include individuals who have poor posture or maintain improper posture for long periods of time, if they have any nerve impingements or sustained muscle contractions. This can be from emotional tension. When you're stressed, you hold those upper traps and those suboccipital muscles tense, or it can be from faulty posture. Trigger points in those cervical and suboccipital muscles are very common in those who get cervical headaches. It should be noted that you may need to refer to a physician if the patient's saying it's the worst pain they've ever experienced, if they have change in personality or change in behavior, that's not a cervicogenic headache. General management guidelines is to fix the impairments that you noted. So we talked about they may have improper posture. You would correct that. They may have tight musculature. You'll stretch that out. Any trigger points can be treated with manual therapy or dry needling. And so the impairments that you have found in your evaluation that cause an increased tension in those muscles, you fix the impairments. And the last is cervical myelopathy. So with cervical myelopathy, you get significant compression on the spinal cord, and this is usually a result of degeneration or central canal stenosis in the cervical spine. And because of the neural pathways, these patients may get symptoms in the upper and lower extremities, all the way to their hands and feet. They may have an uncoordinated gait. They may have some upper motor neuron lesions, bowel and bladder impairment, and like I said, significant signs in both upper and lower extremities. Diagnosis of this is through a cluster of special tests. So there's not one test that would tell you that you have cervical myelopathy, but if you have abnormal gait, reflexes that indicate an upper motor neuron sign, and usually you're over around 45 years old. And this is a progressive disorder, so individuals with cervical myelopathy, if they are opting for conservative or non-surgical treatment, you need to continue to monitor to make sure their symptoms are not progressing. Often these individuals, though, do end up getting surgery for their problems. In the meantime, if you are treating, you treat the impairments that you see. Again, you're not going to be able to decrease the amount of stenosis in that spine that's causing the symptoms. You may even be treating gait training, or treating their gait and working on gait training, treating symptoms into the upper and lower extremities. Additionally, cervical traction has been shown to show some improvement in these individuals, as well as cervical stabilization exercises and scapular strengthening. Alright, that is all for Chapter 15. Again, make sure that you go and watch the videos. They're animated YouTube videos on these surgical procedures. Hopefully they will help you to have a better grasp of what happens when the patient has surgery.